of love your background.
No,
Okay, we're
I'm gonna
live.
make mine better.
Oh,
There we
you're
go.
gonna you're gonna show the actual background?
No.
Oh, I like that one. That's a really good one.
Hello, America. It's 3:00 on Friday, April 24th.
In the airplane restroom, because we have seen that in videos, right?
Yeah.
I'm in none of those places. I'm on the ground, but I am in Dulles Airport, so it's fun.
Yeah. As usual, Lisa is in a transitional location.
That's right.
Melissa is at her house. I'm in Atlanta. And we have special guest Lucia Savage, who is newly retired, therefore able to talk about all the things she's ever thought. Yeah, that's not true. She's not actually retired.
Kind of.
I think she's retired in the sense that she is just doing whatever she wants.
Which is a great place to be.
It really is.
Yeah. Lucia, give us a quick intro to what you're doing now.
Well, a friend of mine who retired from UHC said when I announced that I was retiring, she said, "Oh, you're buying back your time." And so I'm very judiciously deciding what to spend my time on. So I have some projects. I am in the garden. These were just picked a little out of my own garden. I get to spend my time reading the part of the trades I want to read instead of the ones I have to read for my job. So
well done. Nice. And you do have a consulting firm now.
I do. We can talk about that a little bit more because I know you have the swag mug cat. So
I do. I should have brought it over here with wine in it. I still have time. There's still time for it. There's still time.
Yes, it's really noon here, so my mug has water in it. But
nice.
water is the wine of life, or wine is the water of life, or something like that.
Yeah, all those things. Agree, 100%. Okay, we're gonna send Lucia to the back, even though she cannot be fired like some of our guests. But just in case, and she does have permission to be fired. Well, I guess that's true. But she does have permission to pop on and yell at us if she disagrees with any of our commentary in the news show, as she would do on the internet anyway. So, all right, Lucia, we'll see you in a minute. Melissa, what's new? What's going on?
Nothing. I'm running for NJ HIMSS board member. So if anybody here is an NJ HIMSS member, please vote for me. It takes 2 seconds of your time.
If you are a fan of the talk show and you are a member of NJ HIMSS and you don't vote for Melissa, stop watching the talk show. You can't have it. You can't have it. You got to leave. You got to leave.
All of that. Yes.
Get out.
That's pretty much it. I went to the tribal board. I don't even know when the last time we had a show anymore, guys. I'm all over the place. I have nothing to say. You can throw me in the back.
Okay. All right. See ya. All right. Yeah. So Lisa is not on an airplane, but she is in a part of Dulles, which before she put this background up did look much
very industrial from the 1960s.
Homage to the Soviet Union architecture that we all know. Right. So that's what
Speaking of which, I was on the Hill this week and we were talking to somebody and we were saying like, oh, we just came from HHS. And he was like, oh, like that building looks like a Lego. And we were like, I guess that's one way to describe it. It's more like Star Wars, right? Brutalist. It's more like a Star Wars. But he was like, it looks like a Lego to me. And I was like, that's okay.
That's nice.
Lego.
That's nicer than I would have put it. So that's super cute. Cool.
Yeah.
Okay, we've got a food summer garden themed talk show image today.
I'm happy to be the mozzarella of this caprese salad.
I'm not sure how Max, again, this is not an AI image. Max makes all of our things. We believe in people and
it's in their brain. It's in their brain.
We believe in AI too, but whatever. Like, this is worth it. We're not going to screw with that. Anyway, lots of stuff happened. So, like Melissa, our brains are scrambled, but we did have a show on Friday, so we're not too far behind. I think. It was whatever.
So.
Yeah, because we talked to Clay and it was hilarious. Oh my gosh.
Bring in the clowns, send in the clowns. That was great.
So like a bunch of things happened. We'll talk about them maybe. We probably forgot a lot. And then we are going to cover some of the Senate hearings that RFK went through, or all kinds of congressional hearings throughout the past week. So some interesting things said, some interesting Maha stuff going on. So, we'll get there when we get there. Lisa, you sent this over to me and I was like, why is Lisa sending me stuff from like the Nevada Inquisitor or whatever this newspaper is? I don't know. But this is actually, when I actually read it, is actually like a little bit like kind of scary.
So you all know that we are interested in. We're Medicare for All curious over here at the Health Tech Talk Show.
We're so curious.
Some of us call it Medicaid for all, but some of us call it Medicare for all. Whatever. One of the policy ideas, was very much to allow states to create just a public option on the ACA exchanges, where they say, let's just see, let's just let people buy into something that's run by the state, or maybe someday run by the feds, whatever it is. And it was like attacked from like day zero for so many years. It was just like, this is unconscionable. Like, how could you? Like, big dramatics, big like, woo. So a couple of them stuck around, Washington and Oregon. I think Washington and Oregon at first, and Nevada just tried to launch their own to say, can we somehow bring down the cost of premiums, which are like skyrocketing on the insurance exchanges, everyone knows. And the way that they were going to bring the premiums down was to cut broker payments. And they were like, we're not going to pay doctors less. We're not going to provide worse care. We're just going to pay brokers less.
Cut them out. And the broker said.
And the broker's like, not on my watch. And they're like throwing a fit and like suing and like doing illegal stuff and like, oh, whatever. And specifically, they're saying they are not going to tell any clients or any customers about the existence of the public option on the exchange, which is like illegal. And also they were mad because like the state said, well, we have our own like advisors people can call to try and understand their health insurance options. And we're going to ask them to like especially emphasize the public option. And I'm like, and so what if they do? That's the state's plan. Like, of course they're going to say like, you should join the state's plan. Like, I don't know. Anyway, the brokers are really mad about this. Everyone in healthcare is like not equally, but certainly like complicit in bringing the cost of care up and the quality of care down. But like, I would imagine that insurance brokers would be like the least sympathetic of this group. I don't know.
Yeah.
Don't cancel me, or maybe do cancel me if you're a broker. I don't really know. But like, I don't feel super bad for the brokers. Like, it's like, I don't really get it.
I do like how the brokers are messaged though. Like some of the quotes in here were like,
why
would I lead my clients toward a worse option with poor structural design and bad networks?
Somebody gave me some talking points. That's for sure.
Great. That's great messaging for whoever is helping those guys lobby. But anyway, interesting. We'll see what happens. I don't know. Apparently, they expect like 30% of those people who are currently engaged with the exchange to sign up for this plan. So we'll see.
We have a private message from our chat here.
Do we?
Don't mess with the brokers. 6 to 8% of the premium.
Gee, Lucia, is that
maybe our guests will say more soon?
Is that a lot of money? Is that a lot of money?
I don't know. So if 8% of $100 is $8, so just 10x that. And then it's by person, right? So brokers have always, if you look at all the state efforts, the original California small group exchange, where I was general counsel, the Colorado small group exchange famously imploded. The brokers have an important role to play. They're often significant and influential small businesses within their cultural niches, for the Hispanic community, the Black community, whatever. But it could be argued that they don't provide a good service. I don't know, but it is a lot of money, and nobody wants to have their slice of the cheese be smaller.
That is correct.
That's true. We have an article in here somewhere where we're going to talk about the slice of cheese getting smaller. I can't remember where it is. Oh, it's right here. Lucia, stay around. Okay, so Lisa sent me this, and Lisa often sends me like democratic socialist propaganda, so I don't always read her articles.
Well, I commented on Dr. Emmanuel's LinkedIn.
Of course you did, Lucia. That's why you're here.
That's why you're the guest.
So I just read this though, but okay. So I will say I read this and I liked all the vibes in it. I also think he's given a couple really nice podcasts. I think didn't he write a book or something recently, and that's why he's on this bender?
For sure.
Yeah,
he's
done some really nice, I think middle of the road-ish, maybe slightly left of center podcast interviews about, how do we make healthcare cheaper and what are the problems? And I also just, Lisa, be impressed with me, did listen to the Ezra Klein show yesterday on a very long drive to somewhere I didn't want to go, about like estate taxes and like how rich people don't pay a lot of money. And it was like a similar vibes. They're saying like, and they even said like healthcare costs are astronomical. Like the United States needs money. And no one, even the people like us who pay all the taxes because we are rich enough to get away with not paying taxes. We don't
Lucia,
want to change.
Can we talk about Prop 13 today? My favorite other topic that only another Californian will care about.
And that Ezra Klein podcast with the tax expert was fascinating. And
it was so good
about the tax law. It was just fascinating. And really, I think almost required reading for anyone who really wants to understand the overall fiscal health of the country. Just fascinating.
It was super fascinating. And much like this article where Zeke Emanuel goes through like various ways that people could reduce the amount of money and bad incentives in healthcare. You know, like I listened to it because I'm like, how do I not know how to not pay taxes? Right. So that's why I was listening to it to figure it out.
She was she was listening for tips. She's like, give me some hot tips.
Yeah. Basically the I don't remember the name of the expert who he was talking to, but she was great. And she was basically like, yeah, like whenever people have a chance to vote, either they message hard against it, which we'll talk later about other things. Or it's like that segment of people would like to be the rich people and don't want those loopholes to go away.
That explains everything in American politics for the last, I don't even know how many years. People who vote against their own interests, who think that maybe someday I'll be a multimillionaire. And you're like, no, you will not. So therefore, don't vote like you're a multimillionaire yet. That's the end of my stump speech. End the show. That's all I have to say.
I'm like a business owner. I pay 46% tax rate. Like
you're the physician in Beverly Hills.
You are.
And not the person who borrows against their stock and then borrows against their stock again to pay off the first loan and never has actually income because loans are not taxable.
I know, and they were like,
that's the smart person.
Wages are for suckers, or salaries are for suckers, which I hear
they
all the
are.
time. And like, I'm like, okay, but even like me, like we don't have stock, we have cash profit.
Listen. If
I was looking for tips. I was looking for tips. I came away disappointed.
What was it? It was exposed in the Panama Papers, right, Lucia? The whole the loans on loans against your assets scheme.
Yeah, it was basically talking about the difference between a person who has enough capital to generate their run rate through borrowing against capital versus a person whose primary run rate is derived from wages. Wages are taxed. They're not. And once you sort of think about that, it all kind of falls into place. So high wage people pay a lot of taxes.
Okay, so Kat, we're going to set up a scheme where I'm going to lend you money. You're going to lend me money. And then we won't pay taxes somehow.
Is that how it works?
You'll have to be a bank.
Yeah.
Lisa. You'll have to
I'll become a bank. Easy. So will Kat. This is totally fine.
Lucia,
we're working it out.
We did become a media company to, in large part, get free trade show badges. So I feel like this is a scheme we can definitely do one day. Like, we'll figure out how to be a bank. Like, we'll do it. No, but
okay, we got it. We're a bank.
You know, like I didn't have time to copy and paste the insights that the fine author had here, but a lot of it was like really interesting. It's like, wow, these incentives are so bad, and like we kind of need to do something because we're kind of screwed.
Yeah.
So
what would everyone give up? So some of the questions are like, would you give up like cheap prices on generic drugs to have brand name drugs be cheaper was one example. Would you wait another 10 days or 15 days for a specialist appointment? Like these are the kind of questions that are posed as I understand it. And so if people have opinions or thoughts or beliefs about what you would give up to make American healthcare better, definitely shout out. I'd give up paying for senior citizens gym memberships, just to be totally clear.
Same. Mm-hmm.
I'm really good, like silver sneakers or whatever.
100%.
It's done. I'm over it. No way. I would give up MA. Sorry, everyone. I would have everyone be assigned to a federally qualified health center, similar thing. That's what I would give up.
Really?
Sorry again. Yeah.
I would just abolish
the
health
Spain
insurance.
Model.
May the mighty win.
Ooh. Okay. So we know what Kat would do.
Yeah. I'd have, there'd be some, whatever, we'd figure it out.
I said on LinkedIn that I would give up seeing a physician in favor of a nurse practitioner or a PA, but only if the savings were used to fund mandatory home ec in middle school.
Ooh. Are there do you have numbers behind that? Like what? Why?
Because people don't know how to cook nutrition.
Well, that is true.
That's why. And that's what home ec is for. even when I was in middle school, which is before Prop 13, and I know you want to talk about that, it was optional. You had to take either home ec or sewing or shop, right? You had to learn some kind of like life skill with
something useful.
But and I can see the value of learning basic electrical and basic plumbing, but I actually think basic cooking is more important.
It is. It doesn't solve all the problems, but it would certainly be helpful. I would like everyone to have, all of those like basic sort of life skills. And I'd also like people to have like money management too. And like probably most important is like recognizing scams and like fraud and like, unsafe things. Like number one life skill everyone needs is like how to recognize a scam, how to recognize a fraud, whatever, like how to read through like BS marketing language. Sorry to the marketers, including me, for like healthcare things, health things, wellness things, like all those things. That's like the number one thing.
Comments healthcare focused, so I didn't get into like financial acumen. Like, MEC is a good trade-off for an upstream intervention that improves overall population health.
Okay, I have one more thing. If you buy peptides from China and inject them into your body, you're automatically denied all healthcare.
EQ, agree.
You're out. You're out.
If you I don't know.
I mean,
you disqualify yourself.
We'll come back to this topic. This is going to be a hard show. Okay, well, let me go to this one first because I made this deck like 20 minutes ago and it's out of order. Okay, so I got a text from Lisa in my Lively group chat with some really fun members of the healthcare industry saying, OMG, you guys, did we just legalize psychedelics? We did not legalize psychedelics. Lisa, what actually happened?
We did not. Apparently, we are now, they did something about like whatever the schedule that psychedelics are on, made the ability to make them available for clinical trials. And specifically, I think they were specifically talking about ibogaine, which is, I think it's from a bark or something from central southern Africa.
It was a root or something.
Like Uganda.
It's something.
It's
not
super
from around here.
No, but even that, ibogaine has become, there's been a lot more people like writing about and thinking about ibogaine. And there are places where you can do like a clinical-ish or a clinically guided like psychotherapy thing with ibogaine, including in Mexico. There's a couple other places where it's available.
Right? A lot of
for PTSD, for serious, severe PTSD. And there was a New York Times podcast recently where one of the a journalist from New York Times actually like went to this like Mexico like one of the clinics there and did like this full ibogaine experience for severe PTSD along with a number of veterans and other people who had serious conditions, and he talked about it. That you can listen to the podcast, it does not sound like a chill thing at all. It is like really intense and like, so I don't know. I mean, I think there's been some good evidence so far about the use of some psychedelics and some other drugs like this for treating really serious, severe PTSD, which definitely hits veterans. Also hits other people certainly, but there are a lot of veterans who come home with really serious PTSD and other conditions that they can't seem to get relief from. So, this basically, this was just doing that.
Have everything. Americans should have all the things and basically check out. Like we're gonna speed through things at the FDA. Blah blah blah. Also,
but just really quickly. Obviously, no one should ever think that this is any kind of medical advice. But like, but as far as I can tell, and like again, do not take any advice we give you ever. But like on this one, ibogaine sounds like it is not a DIY at home thing. So like, please do not do this, and also do not take our advice in any direction. Thanks. Bye.
We are just girls on the internet. We're not even a real media company.
Totally.
Also, ARPA-H, those guys are back. They're doing stuff. They just announced a big chunk of money that's going to some of this behavioral health stuff, including some psychedelic stuff. I believe this also includes one of my favorite initiatives that I think the government should take on. As a capitalist, I think that we are incentivized to do things that make more money. Once and done therapies do not make more money for capitalists in most cases. So we do not pursue them. Yeah. So something like this, I think, is cool and important. And so that's cool. Like, we'll see what happens. I don't know.
Yeah.
More GLP-1s, Lisa. I'm like over it. Like, who cares?
It's amazing.
I don't
Listen,
care.
this one's good. I will give everyone my personal recommendation here once I go through this program. So TBD, more to come.
Okay, well, just like when we go through the menopause, we will let you guys know how it goes.
We'll let you know.
We'll let you know everything that happens. Maybe we were just talking earlier, like when do we know, Lisa, when we need to start smearing estrogen on our bodies? I don't know. When do we know?
I think it's soon. I don't know.
You think it's like now or soon?
Nah, might be soon. Might be soon. Might be soon. Might be soon.
Maybe someone will type in with medical advice. We'll see what happens.
Yeah.
Okay, cool. Oh yeah, this was exciting. Mostly, I love this. So this is people exploiting the No Surprise Billing Act to say, oh, here's what's covered for insurance, and because everybody else is charging $400K, so can we.
So first of all, this article was like a bombshell. Like a lot of people read it. And then I found myself at a dinner with somebody who actually like works with one of these arbitration companies. And I was like, hey, like, can you please explain to me what is going on here and like why this would be acceptable? And he was like, well, listen, he's like, if the payers in this case were paying something reasonable to out-of-network doctors, this situation wouldn't have happened. And I was like, okay, I can hear you on that one. He's like, and yes, there are some bad actors, but for the most part, like they are not paying anything close to what they should be paying in those out-of-network like interactions. And he said, and these numbers, they're not actually getting paid. Like the payers are just like, no. Like the ruling is coming down from arbitration and they're like, no, I don't think so. Like they're just not doing it as far as I can tell. So this is like Lisa having a conversation at dinner with someone who works in this area. So like definitely, do not like take with a big grain of salt. But he was like, the payers are not actually paying out these awards. They're not doing it.
Well, that's how I get all my information. I feel like it's usually more accurate than the internet. So I feel like that's the right move. Although, can we just call out this ad? 1-800-GO-SMALL.
Go small.
That is what I'm talking about.
No. That is not the most important thing about this article. The most important thing about this article is that guy, that doctor goes by Dr. Penis. And because apparently one of the things he does is penis enlargements.
Yeah.
And his name is Dr. Penis. Dr. Penis.
He apparently they inject Juvederm into that body part. And
let me just say, first of all, this is obviously a New Jersey thing. We just learned that in real time.
Bless New Jersey.
First of all, even if you didn't know where Dr. Penis was located, would you have guessed New Jersey? The answer is yes. So just to be totally clear, like that is obviously where. No, Dr. Penis.
Florida.
Okay, Florida. But I feel like it's more New Jersey. But that's fine. And then I just none of these things. Even though like don't take my advice for anything medical, but do take my advice for anything medical when I tell you do not get Juvederm injected into your private parts. Thank you.
Yeah. Right.
You're good.
I mean, talk to your doctor. Maybe not this guy.
Not a doctor.
But, let us know how it goes if you do decide to do it.
Another doctor, please.
On our fake
please,
news
another
show.
Doctor. Please.
Okay, what's happening? Okay, so this is going into our Senate hearing thing, Maha. So, I the past couple of days have been searching various like phrases like, is Maha still relevant? Is Maha awesome? Is Maha dead? And so this is one of those searches. And mostly I copied these ones because first I didn't know AOL.com was still around. However, what an amazing title. The Mouse That Roared. The Maha Movement. So anyway, I don't know, Lisa, I know you are leaving DC. When I go to DC, I feel like Maha, like it's like, how they've like painted the sides of the Lego building, the HHS, the Humphrey building with all those.
It was still there. It was still there.
Yeah, it's still there. When I first saw that, I was like, oh, wow, I'm like feeling the vibes. This is one of the, like, I have not felt those vibes all year.
I really haven't. I
don't think people are into it. I think the people who still talk about it, I'm like, I just don't know. Like, I just feel like it represents something that like maybe wasn't handled well. And also this guy. So the first result here I did read because I was like, I wonder where he's getting 2 to 5%. Turns out not really anywhere. But this weird Substack that does seem to be kind of hilarious. There's some interesting stats in there. One is that this is actually from a political poll. Half the supporters of Maha believe vaccines are a key issue. Less than half. Okay, I agree with that. And we'll see more of that. And then a separate one found many voters like just kind of don't care. And then up here, this is again where these stats may not be real. This is like Kat and Lisa going to the bar and saying, 2 to 5%. But yeah, according to some insiders, could be us. Who knows? We don't know.
Who's the insider?
It
Me.
could be us.
Me.
Internal pollsters in the administration
Oh
are advising Trump that Maha values are inconsequential and only around 2 to 5% of the voters care.
Yeah,
Honestly,
I don't know.
I kind of think that's true. I kind of feel like if I'm feeling the universe, I feel like Maha kind of screwed up.
But also
like
people, they did, but also it's like people, like it doesn't take much to demotivate a group like Maha. Yeah. And the glyphosate thing, like that was a demotivating thing. They were like, hey, this was actually important to us. And like, you did not come through. So I have some sympathy for them. Like, I appreciate people who are like consistent in their belief structure, which is most people aren't, obviously, including myself. But like,
we'll see some of that here in a minute. So don't worry.
But like, I appreciate they're like, just kidding. You clearly weren't on our side. Like, good. Yeah. Feel that.
Yeah. I mean, also, like, again, like the broad general American population is not thinking about these political trends as a way to, like, you know, get ahead and do things. Like maybe like a few percent of them are.
Yeah.
I think in this case, like the Maha energy was kind of wasted. And like, yeah, they wasted it on things that most Americans actually agree with. Like,
no measles.
Pretty good idea.
We like not having measles.
Right. So there's like some really good things here that were kind of turned around. And yeah, like it's kind of like, I'm like kind of over it. The other thing is the Maha Institute. Like as soon as like the whole thing with Chris Klomp, RFK, like got shifted around and Jim O'Neill got, I don't even know, did that guy ever actually get nominated for the NSF? It's unclear. But
certainly not yet. I don't think it's happened yet.
It was like the next day, all of a sudden, the Maha Institute, which put on the Maha Summit, which apparently is run by RFK's son or some blood relative, started pumping out emails to their email list, of which we are a member, Lisa. And
they do emails like 2 a day. Like it's like genuinely 2 a day.
Like they should have been doing that. Like they missed the moment, in my opinion. Like I'm just kind of like over it. Like, yeah. Okay. So let's see. So we're going to talk about RFK and his hearings this week. So there's some really good headlines, and then we're going to go into a PBS overview. You know, PBS just got unalived. If everybody remembers,
what? They got unalived.
Well, yeah, they got unalived. Like they got apparently a judge said you can't cancel their funding, motherfuckers. Yeah, so PBS
I missed that one.
I'm not sure if they were gone. I'm not really sure how it all happened.
No. It was the Corporation for Public Broadcasting, which funds PBS and NPR.
Yeah. The judge
they,
was
they were like, you can't shut it down. But PBS is funded by viewers like you and me.
That's right.
And so they just lost a big portion of their funding, but they still exist.
Yeah. So anyway, they're around and they did some great coverage. Anyway, yeah. So RFK, like I watched a few of the hearings that I could, and then I was trying to keep up with the coverage. A lot of like in terms of messaging, what's amazing to me about the entire last 2025 of the Trump administration was, wow, it is amazing how much America forgets, or how much they think America forgets. Like some of this messaging is just like outrageous. So this is of course like a little bit snarky, but yeah, the cuts at HHS haven't led to problems. But by the way, we need to hire 12,000 people.
This is really like I know we're laughing, and I know like we are making fun of all this. No, but I'm saying this like as somebody who has lots of friends from CMS and HHS and the rest of the federal government, some who are, all of them who are just like incredibly dedicated to their work, people who are really qualified and who were riffed with like no obvious reason or like clarity. And then they were told that they could apply for new open positions. And almost all of them, huge groups of people, have like reapplied and been like, no, I'm still committed. And they don't get through even the basic screening, like where they're like, I meet these qualifications. No. If you don't meet these qualifications, like, sorry. But first of all, it's not legal, as this article notes, to riff people and say your job is no longer needed, and then just say, JK, we're hiring for your job. This is literally not how it works.
Yeah. And that's not just like a red state or a blue state rule. Like it's like everywhere. Yeah.
That's really, it's just messed up. And again, like people, federal employees are like, they genuinely work with all administrations. Certainly there's a few exceptions here and there who've been like, I'm taking a stand, but most people are like, I'm here to do my job. Like I'm here because I know about this thing, and like I want to help you like not like get sued for it or whatever. So I would really encourage anyone in, in leadership here, whatever, like just put out the rehire notices. Not everyone's going to say yes. Just do that. And then you can hire more people. Just rehire the people who want to be rehired and then move on.
Yeah.
You can fix this.
Talk to Lisa. She's got ideas.
Yeah.
Okay.
I got ideas.
Thing,
Call me.
Other interesting things. Again, this is back to the Maha thing. Apparently, various Maha situations were they're running out of money. Like they're running out of money. Also, this was a great quote from Senator Chris Murphy, blasting the Maha PAC. Moral and ethical mess. Things aren't good, y'all. Things are not good. And then another couple quotes, and then we'll go into the PBS coverage where this is RFK actually saying that he encouraged all children to get the measles vaccine, by the way. He encouraged them all. And he continued on all this stuff. It's all partisanship. It's all tribalism. It's not real. We got more stuff on that. Basically, this is gaslighting America right here. I feel like all of these testimonies are like bullshit. And again, I am pro healthy food. Anyway, so here's some of we got 4 takeaways from our friends at PBS, which, is supported by viewers like you. So donate to them. He again said that it's not his fault Americans aren't vaccinating. Holy shit. You guys, I'm down with weird messaging and but you can't lie. You can't lie. It has nothing to do with me, Kennedy said Tuesday of the uptick in measles across the country. He noted there is a global rise in measles cases, including in other countries. Okay.
We achieved measles elimination status.
Yeah, I don't know. Last time I checked, we were the United States of America. We're the best. I don't know. Who cares? Okay. Forcefully denies there are Medicaid cuts. So this, the Republicans, the R's claim that the D's are making up math about how bad the cuts are. The D's say the R's use this weird reporting thing that basically says if the economy grows at a 4 million % rate, we collect all these taxes. Not a lot of people are born and inflation goes to a certain level. There's actually no cut. So basically, this is why math isn't real, Lisa. This is it right here, because it's just bullshit.
I don't think that's true.
That's
all I can say.
I will say the fact that many hospitals across the country have already reduced their rolls, have already made significant cuts, and are closing in anticipation of the cuts.
Wow.
Means they're probably real. And remember, the Rural Health Transformation Program is only for rural hospitals, and it is only 1/3 of the projected cut. So, okay.
Yeah, don't love it.
Yep, don't love it. This is more just general bullshit. I do like some of the quotes on this one. If you watch some of it, and some of the quotes from PBS, lawmakers of both parties are concerned about affordability. No shit. Kennedy was like, here's some of the things we do. To be clear, America, Congress actually is the one that can make things cheaper in a lot of cases as opposed to HHS proper. And so a great quote from Kennedy that I do agree with is, why don't you do an agreement yourself?
Yeah.
You've had the power to do that for 20 years and haven't done it. Agree. Yeah. And remember, Congress is the group that was unable to pass the subsidy extension for the insurance exchanges.
Yeah, 100%.
And then we have a preview of our next show. It's unclear if it's our next show or some show in the future. Kennedy does acknowledge some cuts are painful. If they achieve that 12% cut in the president's budget, that's $100 billion. 12% of the $100 billion budget. They're proposing slashing $5 billion from NIH. As we all know, we believe NIH is a bet on America, as well as the SBIO program, otherwise known as SBIR by me. And there is a great quote here. There's an argument to be made that we're handing China our lunch by cutting research in America, which I feel strongly that is the case.
I'll just say this. I'll say this one thing, which is that if you just added up the aircraft that we lost in the war so far, and you just took that and hadn't lost it, we would have enough money to pay for all of this.
Yeah. Just saying.
Decisions, choices we make, choices.
Yeah, we we could remove the death tax loopholes, which I learned about in great depth. Also, speaking of taking bets on America, y'all, as we all know, President Trump did sign the law that reinstated or made us start spending again the money for the small business program, SBIR. And maybe, Melissa, next week, when are we having these guys on?
The 15th.
Oh, sorry. May 15th, we're having Jennifer Bland and Commander Michael Banyas, who's over at the NIH. They're going to come on and talk to us about that program with a deadline that is in September. Innovate and show America what's up. You should listen to the show, probably.
Great.
Okay, now it's time to talk to Lucia. Oh my gosh, we kicked her off and now she's back. I don't know. I think we didn't kick her off. I think she just turned her camera off. I thought she went to get a cup of coffee.
She's like, I'm out of here.
Yeah. Lucia, you do have a fan who wrote in here. Who agrees
yeah,
with
there you go. There you go.
Yeah. You know, you guys forgot a couple of news items.
Oh, we always, of course we did.
Not the balance model.
Oh yeah, that was a good one.
Like the USPSTF.
Oh yeah, we forgot both of those. That's true. Let's talk about it.
We already talked about USPTF.
No. That happened this week.
Development this week is A, there was an announcement in the Federal Register seeking nominations, and B, apparently one of the things that Secretary Kennedy said in his 7 rounds of testimony was that he wanted to populate it with experts. So actually CNN has a great piece today sort of juxtaposing who has historically been on the task force, which is people who have the right scientific backgrounds but work in applied healthcare, like in the clinical setting, because you have to have a guideline that your average doctor, nurse practitioner, or PA can figure out how to apply in primary care, versus the Kennedy model. But maybe it's coming back to life. It's a super important program because they evaluate the evidence of whether something is sufficiently likely to prevent an exacerbation that it should be covered without coinsurance.
Yeah.
So this is like when you can get your free skin cancer screening, which everyone should be getting. That's free, no cost sharing prior to your deductible, all that kind of stuff.
Your mammogram is free because of this. Your child's your vaccines, if you choose to get them, are free because of this, because there's evidence that it prevents downstream care. And of course, the politically controversial part is PrEP, which is also a grade A because it prevents this horrible clinical outcome for people who contract or have HIV/AIDS. But obviously it's expensive, and there are people who have moral objections to having to include that in their coverage.
Yeah. I have heard that fears of it being too wild, like ACIP, are overblown. Especially now that they've got some more controls on Kennedy, but that it is seen as very left leaning. And so they're planning to get a more balanced perspective. I did hear about specialists.
But I was going to say, the thing that Lucia was saying is that if you look at who is on the committee right now, they're like primary care focused people.
Sure.
And the reason for that is that, like you just said, most of these screenings, most of like the front facing of this is going to be through like a PCP or a PCP like environment.
100%.
The thing that makes the task force that people have trusted about it is the members, as I understand it, having used the guidelines in my prior job, like lived and breathed them, is they really do approach it as, but is there evidence? So I just posted a thing about this, but the example I'll give is last time they did diabetes screening, there was this incredible population health data about how much more severe was prediabetes in the young adult Hispanic and Black populations. This is actually Trump won and Biden. And, but they wouldn't lower the age for free diabetic screening because there wasn't actually controlled clinically developed evidence. There was just population health evidence on a retrospective basis. And so they said there isn't enough evidence that screening earlier would prevent this problem.
Yeah.
So that to me shows a level of discipline about the evidence that makes it reliable for all the rest of us lay people.
Yeah. I will say, like, I've heard some very encouraging things about what they're going to do with the task force. And I think the testimony that the secretary gave was potentially more inflammatory than reality.
Maybe, and to the
Who knows?
administration's credit, they defended the task force in the Supreme Court case. They defended it aggressively and won. And so they understand its value. I think the proof will be in the pudding about who gets on to the task force and then how those people do their work.
100%.
Yeah.
Yeah.
The other thing was the balance and the bridge model. So actually talked to some folks about that this weekend. Basically, CMMI was going to figure out how to bring in GLP-1 coverage for specific sets of Medicare beneficiaries. And it was not proposed to be for the full indication, right? It was like a kind of a subset. Right now, I think, and obviously in no way qualified to really opine on this, but here we are. It's like a certain level of obesity, BMI level obesity, plus different other conditions, including hyperlipidemia, high cholesterol, and a number of other things. And they really limited it because there's huge fears about GLP-1s bankrupting Medicare. What else is going to bankrupt Medicare? We're all bankrupting Medicare. But they basically, Lucia making us where they couldn't get enough commercial payers to agree to join the program for right now.
Right. That's what I had heard too, that it was so the way the program worked was a Part
D. Yeah.
Part D would offer a benefit. And if you were in that plan and they offered that benefit, you would get the medication at a very low subsidized rate from the manufacturer that included
$50 copay.
Yeah. Well, the bridge program is $50 copay, but it includes lifestyle behavior change. So you can imagine all the moving parts there, right? You could lifestyle behavior change, manufacturers, the Part D plan. And remember, you can have a Part D plan and be a Medicare fee for service. So if you're saving money downstream because of better controlled weight, it's not accruing to the Part D program. It's accruing to the government, right?
Yeah.
Or you could have Medicare Part D with company 1 and then Part A and B with company 2. Same thing. So you think about like everyone wants in our for-profit system, everyone wants their little piece of ROI. I can imagine that the math just didn't pencil out. But it's a big problem. Like, how do we bring these medications to Medicare when the price is high? And maybe the new pill forms will give us more different kinds of medications and the price will fall. Supply is stabilizing. Like, there's a lot of economics in here that just has to settle out.
Well, but the summary is that they're basically continuing the bridge model for now. Like they're like, we'll just pay for it. But here's the question. Yeah, this is what Pooja is talking about. How will this operationally work? Because it's said like the government will pay for it or like Medicare will pay for it, but they're not allowed to pay for it, right? Medicare is not allowed to pay for weight loss drugs.
Well, they have their, like Novo has their deal with the government about what the price is, and the individual pays their $50, which by the way, apparently doesn't count towards your out-of-pocket max or your deductible. It's just a co-insurance that you pay. But because it's in a model program in this little authority, that's not a general program. It doesn't work
like
the same way.
Random extra money.
Today it was a nuance I was unaware of. I'm like, well, that's hard. And then think about it for weight loss. Right now, the science seems to be that people don't stay on this drug persistently. They lose their weight and then they want to avoid the side effects and they get off of it, right? So the bridge program is 18 months long. Who's going to be in it at the end of the 18th month?
I'm just curious because I don't know how they get around. Someone probably knows the answer to this. I don't know it yet. I've not been able to find the answer. Medicare is prohibited from paying for weight loss drugs.
There's a bill for that, Treat and Reduce Obesity Act, and it's been introduced in 5 Congresses. And it has co-sponsors in both houses, but it's very, very expensive.
Yeah.
So how do you do that? I don't know.
Yeah. Well, okay. Well, moving on, because we have a lot of Lucia's LinkedIn activity to cover on the show. So as our loyal fans know, we had Lucia on in the past when we had to get approval from her PR team, and we actually had to like give them talking points. It was like the second time we had to do it ever. One time was, I think, for ONC. But now she's a free agent, so we can talk about whatever we want. But we brought Lucia on to talk about, I think, treatment, the treatment purpose of use, and explain to us how like HIPAA worked. And you, I think, like yesterday or today, had a great, very long comment that should have been a post about covered entities, monetizing data, HIPAA, and all that stuff. And your LinkedIn post, if anyone isn't following, just like put an alert because they're like on fire lately. Because like you clearly are just like, here I am.
Thank you. Thank you.
So what's the argument? And what's your
okay?
What's going on?
Nutshell, right? I'm 100% behind. People should not patronize other adults who want to do stuff with their health information. Like, it's your information. If you want to call yourself Dr. Penis, go for it.
That's what I'm talking about.
Right? For our billboard guy. On the other hand, it also means that we as consumers are kind of in a buyer beware environment. And so when you pull your data out, or you ask an app to pull your data out of HIPAA, and I'll get to what is going on in HIPAA space in just a second, then you need to think about where it's going. And you need to read terms of service, and they vary widely. And one of the things, now that I have time to do what interests me, is I've been sort of rummaging around in some of these consumer apps terms of service. And I just think that companies in this space can do better. They can do better in terms of the terms of service, the drafting. It's just incredibly legalistic. I've written those things. It's not that hard to write it in plain English. And by the way, you can take your legalistic thing and put it in your favorite AI and ask it to write it for you in third grade English, and then check the work. So it's even easier now. So I think there's a lot better. The consumer oriented companies can be a lot better. I see mistakes that have been often made. People slap the HIPAA compliant little seal on their website. There is no such thing. There's a lot of FTC enforcement about the fact that thing doesn't exist.
Mm-hmm.
GoodRx got in trouble for that. And by the way, if you say that, then you have to adhere to the HIPAA rules, or you're just fooling people with a lie. So there's like what's going on the back end. But at the same time, there's also an active industry. Now, Omada never did this. I've never worked for a company that sold clinical data that was de-identified. That's never been a job I have, but it happens. Hospital systems de-identify their data to HIPAA standard and then sell it, sometimes in multiple copies, to pharma, research entities, whoever they want to. It's a source of revenue for them. Devin and Josh Mandel wrote a great piece about this. It's academic, about 5 years ago, Devin McGraw, but it's a thing that happens, and consumers are unaware of that as well. And so like, that's an important thing to look at too. And as the privacy officer at a digital healthcare provider, I was the person who had to answer the questions of people who read the terms of service and said, well, I don't like this thing that you're doing. And we might say, okay, then you probably shouldn't use our product.
Yeah. Did you get a lot of those questions, or the majority of Americans are just like,
no, I mean, it wasn't, I can't give amounts, but it wasn't a significant amount. And people who did it were passionate about it and oftentimes very articulate, but it wasn't a large quantity.
Yeah, it was the minority for sure. That's super interesting. I talked, both Lisa and I talk a lot to various guests in the show about like, people who are like so concerned with privacy, and a lot of patient advocates, right, are like, and I'm like, dude, you don't even know how much your data gets resold, because again, patients don't own their own data. It's the facility data use rights, right? And they sign them off, and the average hospital has how many different ADT feeds flying out, right? Like dozens.
Well, I don't know ADT feed. I'm sort of distinguishing between like health information exchange, which I think has legitimate clinical bases, and probably most people. I mean, what the polling showed when I was at ONC was that like 10% of people polled, and these were large nationwide samples, really wanted to manage it granularly, and 90% were like, please God, just get it to my specialist so I don't have to fill out the clipboard again, right? So that's health information exchange, and that's a really different problem than taking the
consumer data
set and de-identifying it, and then offering a copy of that de-identified set to some other entity so that they can do whatever they're going to do with it. And it could be legitimate drug discovery, it could be legitimate public health research, and it could be something else, because you're just selling it. So.
Yeah. Wild. Well, the argument you made this morning was about, what's a covered entity, what's not, like, what is everybody able to do? What's the argument out there?
Yeah. Well, so the thing people should know is that covered entities apply to people who bill clinically for claims. So you could have a health app where you're getting legitimate services, but if you're paying cash and there's no insurance billing, HIPAA is just not going to apply. And HIPAA is a law that applies because of the business's function. You can't volunteer to be in HIPAA. You could volunteer to adhere to HIPAA standards, and then you would actually have to meet those standards. So, for example, if you're a company that voluntarily says, I comply with HIPAA, but you're feeding your session IDs back to Facebook when people click through to your ad, that would not be adhering to HIPAA.
Shout out to Hours Privacy. If you are a company who has an app and you're like, I would like to say that I adhere to HIPAA, but I don't actually have to adhere to HIPAA. And I also would like to advertise on Facebook. You should definitely be working with, at the very minimum, an expert, but also there are tools now that will help you not go against these things that you have clearly aligned yourself to. But don't just do it. Don't just set up a health app and be like, lol, I'm going to advertise on Facebook. Don't do it.
Yeah, and it's interesting. I mean, when you think about how a health system gets their patients, the ones that got in trouble for tracking were doing this direct-to-consumer advertising for HIPAA activity, and the process of pixels was feeding back the name of the person, because Facebook knows exactly who you are when you're logged in, that you were looking for pregnancy services or HIV services, or even just like, primary care services. And back in the old days, the way you got patients when you were in a health system was you put up a billboard during open enrollment. Pick me as your network system, right?
Yeah.
That's generic.
Yeah. Okay, so another thing that I saw this morning when I woke up, as I mentioned, we love Ryan Howes. We like getting in fights with that guy. Lisa and I had to explain to him that, like, when we get in an argument with him or like are into the arguments of others, that's just because that's what engagement is about. So I hope he does not take this.
It's okay to disagree, buddy.
It's actually awesome to disagree, and it's great for engagement. Anyway, he posted this morning, like, kind of a, I can't tell if anything's written by AI anymore, but like something that was like, like commenting on some of the layoffs at large AI companies, and just saying, are we going to see this in healthcare? And, listed a bunch of stuff about like labor costs generally and shortages we have and augmented care teams. And you wrote, I just want to quote it because like it was like such a Lucia thing to wake up to. What this tells me is there are no realistic scenario where AI has a low cost to implement in healthcare. You didn't even put a period on the end of it. It was so like.
People keep talking about like AI agents are going to replace the humans, and there is a scale to AI that probably can't be easily scaled with humans. But ask somebody what it costs to tokenize one token for one query to a large language model, an OpenAI, an Anthropic, whatever, right? I read an article just last week where some company, and I think it was a healthcare company, had blown through their AI query, like their use of their contracted AI entity, their entire year's budget by April 2nd in one quarter, which means they were 3x lower in their price estimate. And I'm sure it wasn't cheap. Like, it is not free to use AI, data science, engineers, the tokenization, the profit margin are on both ends. I think that when we think about innovation in healthcare and reimbursing the healthcare professionals for appropriate AI, that's been a theme of the government for a year and a half. Like, we have to really have good data about what it's going to cost to use AI to make healthcare better. Lisa's been around long enough in the HIE space. They have this conversation with the HAs. Is it really going to lower the cost because I have this new thing I have to pay for?
Right.
Yeah, and I mean, I also just had a conversation with some folks from CMS about this today too. Like, okay, my great idea that like technology should be deflationary, it obviously hasn't been proven out yet. And so, of course, number one, we can't create billing codes for AI because that will certainly not make it cheaper. So then you need another way to pay for it. But you have to prove out somehow in this payment model that like it is going to be deflationary and reduce the cost of care. We are not really there yet, and we don't have great models for that. Yeah. We have some ideas, of course. I don't know if you're allowed to, if they made you sign many things, but like access model, for example, which Omada is not in that first list of
decisions were made after I left, and I have no
no knowledge.
Also, I don't know.
Perfect. But that's the one idea that they have, right? Is like paying on technology, paying for outcomes. So that's all they have.
Yeah.
Yeah, but I mean, it's a bigger problem. That's like a symptom of the condition, Lisa. So we have an entire infrastructure that evaluates what it costs to run an MRI center and what it costs to run an ambi-surg center and what it costs to run an infusion center. And we have not done that fact finding about what does it cost to run an AI supported clinical practice. And we certainly commented on that when I was at Omada many times, and that's a matter of the public record, but like that's where the innovators and the agencies have to engage in conversation with each other. So I'm working on some plans for that. More to come if we manage to get them off the ground. But how do we foster that conversation actually in a rapid way? It can't go as slow as just do an RFI and then do a hearing and then do the rulemaking. Like remember substance use disorder, and it like took 7 years to get a new regulation, which then even didn't even fly. It cannot be like that. It has to be fact finding that's a lot faster, but it likewise can't be based on, an analyst in an agency checking the prices on a couple of DTC websites. That doesn't work either because it's expensive to do AI.
It is expensive. It is expensive. And it's also like patience, right? I know that's of course the big argument we hear all the time is like, well, what happens if something bad happens to a patient? I mean, bad things happen all the time to patients. Right. So I do think, there's lots of ways to look at that. But I agree. And I think people freaking out about the access model and everyone not signing up, right? That's indicative of the challenge too. People think they're going to make money.
I mean, it's 150 companies, so it's not no one, right? And there's some pretty large companies in there. It's just not all the large companies. And every company has, a business model and a business plan, and maybe they made choices for their capital already when access kind of dropped into the world. If they planned their 26 budget last fall and access was announced in December, maybe you can't.
Sure. But here's a hypothetical, as we've talked about on this show, Lucia, that may or may not be true, and may be rumors that one of us have heard of a bar. But like the big rumor is that Hinge and Sword, is it Hinge? Yeah, Hinge Health and Sword were the ones pushing for the access model, right? So that would have taken, those conversations take a long time, and so they would have, if it was a budgetary issue that they weren't planning for the right things, like. They were involved heavily in that. So the rumor is that we may or may not hear at the bars sometimes, right? Is that like they thought they were going to make money. And said
just that they have a cost structure that doesn't support that kind of money. Like they have costs to deliver.
Proven, right? Outcomes aren't proven that you're going to be able to help these people out better than you would in a normal traditional care setting. So I agree. I think more work needs to be done, and we're pushing pretty fast.
Abe has said they started low so they could move, and that's a pretty standard negotiating technique. With you low ball to see how much force you have to do it. So they could up the dollars in a future point. The other thing that's interesting to me about it is I'd love to see like a geographic heat map of where the 50 companies are. Because there are very few that I think are nationwide. And I think within a community at a small scale, you might be able to really succeed at this. But the point is we have, early chronic kidney disease and mental health, PT, all over the country, right? And so we need a thing that actually reaches more widely geographically.
Yeah.
Just remember, you're not required to use technology in any way for this program. It is an outcomes-based. I know you knew that. I'm reminding Kat because she probably doesn't know that. It's not just Lucia knows everything. No, but it's just you're not actually required to use any particular type of technology. It's just designed to make it hard.
Except for the data.
The data fee. Sorry, you're right. You are supposed to use APIs to exchange data.
Yeah.
But you don't have to even do app-based care. You could have a doctor's office calling people on the phone and you could do that in theory. I don't know.
Well, okay. So we got 2 more minutes, and I want Lucia to end with an awesome story that she told me on email. Lucia is one of the few people who believes I still read email, and because she actually sends them, I do read them sometimes. But so if anyone doesn't know, the reason that I'm causing trouble with Academy Health and probably making them roll their eyes is because of Lucia. She nominated me for a thing, and I'm a co-chair of Health Data Palooza, and she sent me an email about a company to think about, Kintsugi. Tell us about this Kintsugi.
Kintsugi was a company. Well, Grace was the founder. It had this technology where they had a large language model that could detect emotional changes via voice patterns, and they had actually done an RCT in Japan, but they were in conversations with the FDA, but they ran out of money before they got approval to market. And the thing about Kintsugi that and then what Grace did is she took the entire data set and open sourced it on Happy Face, where they're actually using it to detect nefarious actors on the dark web by voice patterns. Like, how cool is that? Total open data. And that's why it ended up in the Health Data Palooza list, is like, Health Data Palooza's origins were open data. What a great thing to do with your data set. But Kintsugi is also one of the many stories we have about a really promising innovation that, for whatever reason, the runway isn't long enough to get through FDA clearance and into coverage, right? There's a bunch of different steps you have to go through. And just because you're allowed to market doesn't mean you're covered.
Yeah.
Kintsugi, they tried to do it right. And there's a great Substack by, I forget the guy's name, about it. I think it's on the link I gave you.
Yeah.
About how they tried to do things right. And I just think, and that's why it's a,
the author is the Giovanni Colella, the Castlight CEO. Yeah.
Yep. And he had very articulate, way better than I could ever say. They tried to do it right. And by the way, what Grace did with the data was also right. Now, I happen to know Grace, but I just think, it's a story. Akili has this story. Therapeutics has this story. There's a story about that. And people want to place the blame on the FDA, but maybe the responsibility is on the runway and the way the VCs build that runway or help guide. You need to 30% for clearance, 30% for coverage, 30% for go to market, whatever it is.
Yeah. Yeah.
With tempo and the access model, something like this, they are trying to do things to speed it up really quickly, because I cannot handle when someone says something is incorrect. I'm sorry, Matt. This is incorrect.
You and Lucia both. This is like
the
facts matter crew here today.
No, the facts matter here, right? So the applications were due on April 1st, and in fact, they extended it to May 15th. And by the way, I have it on pretty good authority that they accepted everyone who didn't have who wasn't missing information in their application, because you still have to go through the participant agreement thing, and there's other things like that. So if you wanted to just apply and then decide later, everyone who knows what they're doing in this space or is from one of these big companies probably would have been able to figure out that they could just apply and not commit necessarily. They may not want to do that for risk reasons. Like Lucia said, it could be a budget thing, all kinds of things. But if you can spell your name and have Medicare Part B billing, and you're a Medicare Part B biller who's not in pending status, that's a lot. Okay, if you're a Medicare Part B biller and your NPI is not pending and you aren't being investigated in 7 states, you probably would get in. Just saying. Maybe that's, to be fair, this is America. Maybe that probably does exclude a lot of people. That might exclude a lot of people. Spell your name right. I don't always do that, so
Anyway,
okay. Lucia. This is Lucia's retirement. If you are a retired person and you are not working as hard as Lucia, just give it up.
If you aren't sitting around reading vendor contracts for fun, I don't know.
So here's the thing: is right. I have things to say. I want to fix healthcare, but I have to be working with people where I like the people. I think the thing that they're doing is really going to move the needle, and I'm going to have fun. So reading a vendor contract and reading marketing materials, of course, I know how to do those things. Probably not very high on my to-do list right now. More like explaining Kintsugi and talking about, balance and planning and strategy. That's really where my head is at.
Yeah. Also,
nice.
Lucia does care about facts and knows a lot of stuff as a critical thinker. So you should probably hire her if you're cool enough.
Yeah, dude.
Though she might say no.
She might say no.
I have a measles vaccine. Well, I'm about to take an overseas trip, and for that, I am required to have a measles vaccine.
Are you required to have your measles vaccine? I mean, if you want to, I don't know, go to elementary school. I think yes. Well, actually, maybe counties,
not. Including, listen, I live in the South. I live in Georgia, and my children are required to get the measles vaccine to attend public school. So I do feel like this is the move. So I don't know. I don't know what to tell you. Anyway, Lucia, you're the best. Thank you so much for coming on the show and telling everybody your stuff. You're awesome. Everybody call Lucia. How can people find you?
LinkedIn is the best way to find me.
Yeah, and also put alerts
All right.
on Lucia's stuff because
Yeah.
it is a hilarious thing.
For sure. I'm always saying
Yeah.
something interesting, and I write my own stuff. There is no AI involved in composition, which is why there are mistakes like no period at the end of the sentence.
I thought that was like on purpose, just to be like,
It's great. It's great. Awesome.
Anyway,
All right.
okay, all right.
Thanks,
Happy
everybody.
weekend, America. We'll see you later.
Thank you.
Bye.